Welcome everyone to our webinar titled Falls and Midlife, a Scoping Literature Review facilitated by the Fall Prevention Community of Practice. My name is Shamiza Allard and I am the Knowledge Coordinator at the Ontario Neurotrauma Foundation, also known as ONF. ONF sponsors the Fall Prevention Community of Practice, Loop and Loop Junior, along with the annual Fall Prevention Month campaign. So before we begin, I'd like to give you a quick rundown of the Zoom meeting platform. So your screen may look a little bit different depending on the type of computer that you're using, but if your Zoom application is opened in full screen, you can double click or press the escape button on your keyboard to exit full screen. There should also be a button at the top right corner of your screen that says exit full screen like this. The webinar technology does consist of two parts, which are audio and visuals. Both the visuals and the audio are provided through your computer monitor and speakers. So to test or adjust your audio settings, look for the audio settings or join audio button in the bottom left corner of your screen like this. So this will provide the options for testing your computer microphone and speakers. So now if you look to the bottom center of your screen, you will see buttons that will allow you to access the chat box and raise hand feature on Zoom. So the chat box allows you to send messages to webinar presenters and other webinar participants. And you can use the raise hand button if you want me to connect with you through the chat box. If you need to leave the webinar at any time, click the red leave meeting button in the bottom right corner of your screen like this. So if you have any questions about the technology at any time during the presentation, please type them into the chat box. My colleague Marguerite and I will be monitoring this. Alternatively, you can email me at shamiza.allard@onf.org. I'll put this information in the chat box and I'll work with you to resolve any of your technical issues. So the webinar is being recorded and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. Okay, so I'd now like to introduce our presenters, Dr. Aleksandra Zecevic and Alain Gagné and Allison Sterling. Aleksandra is an associate professor in the School of Health Studies, the Faculty of Health Sciences at the Western University. Alain is the program director for injury prevention at ONF. And finally, Allison is the knowledge broker for the Loop Fall Prevention Community of Practice and a freelance consultant on health promotion and knowledge mobilization. So for complete bios of the presenters, please view the Zoom webinar invitation. So without further ado, please take it away, team. You may now share your screen.
Thank you, Shamiza. We'll wait for the slides to show up and welcome everybody. This is Alain Gagné. So I'd like to start by telling you where this idea came from. Next slide, please, Alex. Thank you. So the idea of looking into falls and midlife came about quite a few years ago. If I'm not mistaken, I think it's about 5 years ago that we got this question. We know that the literature is very full in terms of talking about fall prevention in children as well as in older adults, but not as much on midlife. So it was actually a question that came from public health units. And from there, we had a webinar back in the day. And we're having a bit of an update on this issue with this scoping review. So this is technically where it came from quite a few years ago and having more information now. Of course, it sits well in the lifespan approach, but as I mentioned earlier, the emphasis has been more so on the other ends of the spectrum than midlife. So that being said, the Ontario Neurotrauma Foundation, for which I work, we commissioned the scoping review with Aleksandra and her team to examine current knowledge, identify gaps, and implication for practice and next steps. And this is where you will be coming in at the end, where we want to hear from you. And there's going to be a little bit of an interactive part. So please stay tuned for not only the presentation, but the discussion afterwards. Next slide, please. So first of all, we would like to hear from you. So are you working on fall prevention and midlife in your practice? So we're having a poll. I'll give you a few seconds to answer, maybe 15, 20. I know it's not always easy with the technology. Great. And most of you, 50% of you said yes, and 30%, 36 said no, and some it's not applicable. Great, thank you. Next poll question, please. So the next question is, are you anticipating that falls in midlife will be a focus of your work in the next year? Please take a few minutes to answer. Great, thank you. What are the results? So most of you say that they do anticipate that it will be part of your work. Some of you know, and others it doesn't apply. So thank you. And without further ado, I'd like to ask Aleksandra to start the presentation. Thank you.
Hi, and welcome. Thank you very much, Helen. Sorry, I had a little trouble finding the mute button. Now it works. Everything is fine. In the next 20 minutes, we will present findings of the scoping literature review on falls in midlife conducted by Western University in collaboration with and support from Ontario Neurotoma Foundation. I would like to express my sincere thanks and acknowledge contributions of co-authors Daniela Bozo, currently a Master's of Gerontology student at Brock University, Alison Sterling, and Helen Gagné. This presentation will start with a brief background, followed by methods, findings, conclusions, and a take-home message. According to the World Health Organization, falls are a major public health problem, especially in children and older adults. Childhood falls are associated with development, curiosity, and risk-taking behaviors. Adolescent falls are linked to alcohol consumption and risk-taking behavior, and falls in later life are results of aging process, functional decline, and inadequate environments. However, the implications of falls in middle-aged adults at ages 40 to 64 have not received too much attention, nor did connections and patterns of falling over lifespan. So the purpose of this scoping literature review was to answer two questions. What is known about the characteristics of falls occurring in midlife? And how falls in midlife relate to falls later on in life? We follow the 6-stage framework for conducting scoping literature reviews originally proposed by Arksey and O'Malley in 2005 and modified by Levac and colleagues in 2010. We identified 2 research questions, then we identified relevant studies, selected documents for inclusion, we charted the data, collated, summarized, and reported the results, and now we are soliciting your feedback at the stage 6 of consulting the stakeholders. What is a scoping review? It aims to map key concepts, main sources, and types of evidence available for the topic. It conveys the breadth and depth of the field, and it is undertaken to generate future research questions. Please note that scoping literature review does not assess the quality of information sources. In the stage 1, we identified the research questions, as I presented before. To identify relevant sources of information, in consultation with a librarian, we accessed 3 online databases, CINAHL, Embase, and Medline, using mesh terms for 3 key concepts: accidental fall, middle-aged, and longitudinal studies. To identify appropriate gray literature, we used an open access guide for navigating gray literature called Gray Matters, and also networked digital library of theses and dissertations. In a stage 3, we selected sources, and that selection was shaped by a set of inclusion and exclusion criteria. Our time filter was set to years between 2000 and 2019. Middle age was defined as 40 to 64 years of age. Only longitudinal studies published in English language were considered. The articles had to report prevalence rates, risk factors, or fall descriptions, and participants had to be community dwelling. We excluded literature on work and sport-related falls, as well as case studies. While reviewing titles, we noticed a number of studies on assessment tools and studies assessing their feasibility, which was beyond the scope of this research question. So all these studies were excluded. Documents that passed these filters were read and summarized in a data extraction table. Once the data was charted, in phase 5, we completed collating and numerical analysis by summarizing content in columns of the data extraction chart. Main points in each column were summed up in brief statements. Patterns of similarities and findings of the included studies were condensed into 5 distinct themes, and conclusions were drawn for each theme. In this final stage 6 of methods, we're now inviting you to participate. So, what did we find? This flowchart describes application of inclusion-exclusion criteria that helped identify most relevant records. In total, 5,136 titles were identified initially. Duplicates were removed. Titles and then abstracts were reviewed for relevance and satisfaction of inclusion-exclusion criteria, producing 30 full-text articles from research for review, and then additional sources from gray literature and hand searches were added, 8 in total. So we reviewed 38 sources. Here, I'm going to present what we have learned from research literature. Then Alison will present lessons learned from gray literature and recommendations from all sources. Of 30 full-text research articles, 27 came from longitudinal studies and 3 from case control studies. They came from 28 distinct groups of authors over the period of 19 years, indicating that there were no hotspots of research on falls in midlife. Age range was from age 15 to 95, and midlife was often just a part of the study on falls or injuries over the lifespan. Authors used numerous ways to define midlife, and some examples are 25 to 63 years of age, 40 to 64, 55 to 64, etc. All studies included both genders, with 22 having more than half females. Data sources in reviewed studies were large population administrative databases, hospital registries, and in 10 studies, data was collected by authors. There was a great diversity in prevalence reporting with multitude of units of measurement, which made comparisons difficult at best. Here are some examples of how rates were reported. Now, let us look at the 5 distinct themes that emerged from content analysis. The first theme was about populations. One of the most important findings of this literature review was emergence of 2 distinct bodies of literature where 11 studies focused on participants with chronic health conditions such as stroke, spinal cord injury, intellectual disability, diabetes, rheumatoid arthritis, multiple sclerosis, and orthostatic hypotension. And 19 studies focused on general population. Please note that here we're talking about bodies of literature and not a specific study reporting on 2 different populations. IND2 consolidated the information we found about prevalence rates. Only 14 studies reported prevalence rates for mid-age adults, and it ranged from 8.7% to 35.8%. Now, here's an interesting example for all of us here on a call who are in middle age, and especially ladies, because this is information for women. A large international study by Peers et al. Conducted in Australia, Netherlands, Ireland, and Great Britain in 2018 reported increase in fall rates for women from 9% in early to mid 40s, 19% in late 40s, 21% in 50 to 54-year-olds, 27% in 55 to 59-year-olds, and 30% for 60 to 64-year-olds. Team 3 consolidated the evidence we found on fall-related injuries. They were reported in 6 studies involving the general population. Rates varied from 11.5 to 30% for women, and women seemed to be injured more. But the study of Talbot et al. Reported high percentage of fractures for men. Interestingly, a Korean study by Hong reported middle-aged adults aged 45 to 64 that they had the greatest proportion of fractures, 42.5%, and it was higher than for older adults, which was 32.7%. In Team 4, we consolidated evidence on causes of falling in midlife, and it turned out that extrinsic causes, such as tripping and slipping during ambulation, were the most frequently reported. Sources also mentioned walking for women and vigorous activity for men, followed by outdoor environments that included uneven surfaces. And we also frequently found intoxication and alcohol use. For special populations, the risk of falls was frequently attributed to intrinsic factors. Final team, the risk factors. In general population, risk factors for falls in midlife reflected activities, habits, and functional capacities of people between the age 40 and 64. Extrinsic factors are environmental in nature, with prominent presence of ladder use, stairs, snow, and ice, while intrinsic risk factors included physical activity, alcohol use, smoking, obesity, health issues, and lack of sleep, specifically less than 5 hours of sleep per night. For special populations, intrinsic factors were dominant and revolved around chronic diseases, medication use, substance abuse, mobility impairment, etc. Considering that some of you might be involved in falls prevention for these special populations, we have included on this slide specific risk factors for each population. Now I'm going to hand it over to Alison.
Thank you, Alex. I'm offering an overview of what we learned from at least 8 documents of gray literature, and I thought I'd just explain that gray literature includes the data and surveillance reports, things that come from CIHI and hospital data and injury reports, and also health agency research reports like the Grey Bruce and Waterloo Region's public health units reports on falls across the lifespan. So those give us some of the area. There's also a couple of dissertations from New Zealand and Australia, which add to our knowledge on populations and health systems work on falls. So some of this data that is reported regionally, provincially, and nationally can certainly help us establish trends, but it's widely variant, as you can see in some of the prevalence things, and Alex spoke to that. To summarize that, all those numbers there, consistently, the emergency department visits for fall injury are between 2,000 and 3,000 per 100,000 population. One interesting thing is that you'll see that in rural areas, such as Grey Bruce, there's much higher prevalence, almost double at 4,000 emergency department visits per 100,000. So that's sort of an interesting part that we can start to see that. It is a similar picture for the rate of hospitalization at 200 to 300 per 100,000. And again, it's higher in a rural area. The risk factors and mechanisms of falls certainly echo what was reported in the longitudinal studies and the case report studies. There weren't any surprises here about the risk behaviors and so on. So both the risk factors and mechanisms were similar. And the next slide shows us the interventions that were suggested and some of the recommendations. So this is a long list that we have here. It's very full, but we wanted to give you a very broad that list of interventions and recommendations to help you think about some of the ideas, to a sort of an idea generation across your wide fields of practice. We did not identify any clinical trials that were testing interventions for midlife falls. So these proposed fall prevention interventions for the middle-aged adults were the ones that were extracted from the gray literature. And they include some obvious ones about addressing risky behavior, such as hazardous levels of alcohol consumption, and providing education about the importance of lifelong participation in physical activity. safety education for outdoor sports and recreation. And an example of an intervention that was described for this particular population was the DIY or do-it-yourself falls campaign that was implemented to reduce ladder falls in New Zealand. And they had a number of components for that, as well as very good results in terms of what people said they would do in changing their behavior. So that was an example, but directed at this particular population. Some of the others were to offer safety modifications in homes offered to those who spend most of their time at home, such as older and middle-aged adults. So looking at those environmental modifications. And another intervention was to create adequate rehabilitation and social supports, such as exercises to restore balance and muscle strength. So those are some of the interventions that were proposed, and the overall recommendations were extracted from the research studies, and they include things like develop interventions and certainly test them, raising future research questions, such as investigating the relationship between leisure time activities and falls, and certainly start earlier with screening and assessments, to also target activities of daily living for fall risk. So those are the general population, but they apply for it. In special populations, we really see a need to have an overall greater attention to this issue and to better guidelines on fall prevention applied for any age. More research is recommended to understand the circumstances that contribute to fall-related injuries. And for example, to look at orthostatic hypotension thresholds, like where do they change in terms of fall risk with particular age ranges. So now I'm going to pass it back to Alex to wrap up and present conclusions.
Thank you very much, Alison. So in conclusion, here are the answers to our two research questions. We have learned that there seem to be two distinct populations of midlife fallers, the general population and special populations of adults affected with chronic diseases. It appears that many chronic conditions, such as arthritis or type 2 diabetes, start developing in midlife, which has implications on falling and may predispose mid-age older adults to risk of falling later on in old age. We have also learned that prevalence rates for falls in midlife are comparable to rates reported for older adults, but causes and locations are different and more extrinsic. More importantly, there is a sharp increase in prevalence of falls in middle age and injury rates for women, and this requires special attention. As for the connection between falls in midlife and falls later on in life, it seems that falls in midlife are a prelude to falls in later life. So the take-home message comes to this. Falls in midlife require further exploration to establish patterns over the lifespan, determine influence of chronic diseases, establish clear fall incidences, causes, and risk factors. Researchers need to establish consensus on definitions, units of measurement, and outcomes so research findings are comparable. Collectively, we need to work on creating the best fall and injury prevention interventions for midlife adults. With this literature review, we have achieved our goal of drawing attention to falls in midlife so that this information can be utilized to better inform future prevention practices. As I wrap up, I would like to inform you that an infographics with results of this literature review, shown at the right margin on this slide, has been presented at the Gerontological Society of America's conference in Austin, Texas last November. A file with this condensed version of the major findings will be available to you together with slides of this presentation. Thank you very much. And now we're going to open up for questions. Helen?
Thank you, Alex. So at this point, what we would like to find out from you is if you have questions about the presentation for Alex and Allison, you can put them in the chat room. I'll read them out loud for Alex or Allison to respond back. This is just prior to the conversation we will be having, so we're just focusing on questions on the presentation. And maybe I can ask the first question as you are busy typing away in the chat box. Alex, will there be a manuscript available about this research and this study?
Yes, we are working on consolidating all the information and writing it up. We have already drafted the manuscript and it will be available, I hope, before the end of summer.
Great. Okay, the first question. Is there, that's from Leanne, and she's asking, is there any evidence of the effect of footwear on falls, especially in women?
We did not extract anything on footwear, no. But that is a wonderful question, and I will pay more attention, and if I find anything, I will be sure to let Luke know.
Great, thank you. The next question is from Cheryl, and she said, you mentioned medications as risk. Are they the same medications that have been shown to be risks in older adults, such as psychotropics?
The medications came strongly for special populations, and these articles on different chronic diseases, each disease has its own combo of medications. So in an unrelated study to this scoping literature review, we are working on trying to really find out what causes injury when it comes to medication. But I believe, I cannot say with a certainty, but we will provide a more specific information on medications as it's available in included sources. Thank you for that idea.
There's another question. Are there plans to expand this work to in-hospital falls?
At this moment in time, the scoping review is telling us what is available, like what is the breadth and depth of this literature, and hospital admissions are frequently related to injuries of people that are community dwelling. If that is where this research should go, that would be very good. We just have to be mindful of funding that's needed for it.
Okay.
In the future, good idea.
Thank you. Do the recommendations you have made from this literature review, do these apply to the special populations you mentioned, like persons with diabetes and MS? Recommendations related to interventions, are the interventions you recommend also pertaining to special populations?
Allison, would you like to take this?
I didn't see, there were some related to specific populations, but I think, Alex, you're more familiar with which ones on the recommendations. As I recall, there were some in a couple of the ones around diabetes and stroke survivors that were related to this population.
Yes, I would agree. If you look at the bottom of this slide for special populations, these are the recommendations extracted from included articles or sources. So both stroke services and rheumatoid arthritis are inviting more priority for falls prevention in midlife for people who have survived a stroke or who have developed rheumatoid arthritis. So they're saying the prevention strategies are needed for any age for these special populations, and also diabetes.
Great, thank you. Is it still a recommendation for clients at risk for falls to be on medication for bone health, such as vitamin D and calcium?
We have not seen that in the literature on midlife falls, but I will make sure that when we visit medications that I try to find additional information for this. Thank you.
Okay, and next question is, could you please review some of the highest causes in both men and women?
Yes, the outdoor, if we just go back to the theme that talked about causes. Now, one has to think and distinguish between cause of fall and risk factor of a fall. So risk factors are unmanifested many times, so they're just potential of something happening, and causes are the things that did occur. So different studies study different things. Some are studying what is the potential for falls or injury, and some are studying what did happen. So causes, tripping, slipping, colliding, loss of footing on staircases, that is frequent in midlife literature, and also vigorous activity and walking. So a lot of things in midlife are related to outdoors activities. And that comes also like uneven surfaces were contributing factors to falls. And there is a lot of outdoor falls and in public spaces and places. So if I would shed the light on some specific area that should require more attention now, immediately, that would be the outdoor activities.
Thank you. There's another question here. It's a little bit long, so it's in the chat room if you need to read it, Alex, but I'll read it. Didn't the Mobilize study show that older adults' falls are similarly split between the healthy active and those with health conditions frail, with the well falling outdoors related to extrinsic causes and the frail falling indoors related to intrinsic causes?
It's Allison. I noticed that that's the Mobilize Boston study, I believe. That I'm not sure that it was included in this literature review, but I'm familiar with it, and it does add to or reinforce some of the findings about the extrinsic or the outdoor environmental ones. For people who, that's where you were finding more of the causes of falls, so very similar. It reinforces the same findings that frail or inactive people who are indoors were more likely to be having more intrinsic issues of what, sort of behavior or action or what was in their environment that was making it more difficult to control. Not sure if I answered that, but I don't think that particular study was in our literature review.
Thank you, Allison. And I just would like to add, if this is about older adults, the chances are that we didn't capture it because our exclusion criteria was up to the age of 64. But just like, it's logical. The falls will occur where people spend most time. So if older adults are spending more times indoors, of course, more falls will occur there. More active, middle-aged adults spend more time in activities outdoors in public spaces and engaged in activities that require outdoors, being outdoors. So yes, the falls will always occur there where people spend most time.
Okay, so there's one last question and then we'll move to the discussion. So Janice, I know you asked, is there any other medication suggestions? I'm not sure that, I don't know if that's a full question, but that's what you wrote. Any other medication suggestions?
Thank you, Janice, for this question. I will go back and really try to sift through medications that was reported in sources that we reviewed, just to provide maybe a table. And if you would like, at the end of the presentation, you will see the email address for me. I'll be happy to send you information on that.
Great. And the last question, really last question. It's, did you include in the literature review falls recovery techniques such from tripping?
That is really interesting, and I wish we did, but recovery techniques we did not intentionally look for. So I love that topic. I used to do biomechanics for 15 years of my research life, and I think if we pay more attention to recovery strategies, we might see less injuries. But thank you for that. We don't have information on that in the current scope of this literature review.
Great, thank you to you both. And Alex, if you can move, so we'll close the question period for the presentation and move into the next phase of this webinar, which is to have a bit of a discussion. And I invite you to post your comments in the chat room. So the first question, on the basis of what you just heard, what kind of additional information would you need to support your work for fall prevention in midlife? What is it that you would need? And please use the chat room for your responses. Or you maybe have some other comments. Okay, some people are mentioning common injuries. People are mentioning that they would need more information on ladder safety. Clinical guidelines and greater research. Okay, those are good. Any kind of information that more ladder falls at Christmas and otherwise are huge. Yep.
Yeah.
Any other information? Okay. Effective and evaluated interventions toward this topic would help.
Yes.
I'm using the Feldenkrais method for fall recovery, harm reduction, and balance strategies. I am interested in research on the benefit of using these strategies. I am aware of one study in Australia, getting grounded gracefully. That's one comment. Another comment is how to be safe while participating in outdoors activities. That would be more information needed. And of course, fall recovery strategies is another one. I have the knowledge to teach how to fall, but the middle-aged women do not see the necessity. Okay, that's a good point. Relationship between physical activity, exercise, and fall prevention in midlife. Knowing the stats and then educational material for the public. Another one is slip, trip, and fall is too generic. Need more specific cause like shoes, environment, rushing, etc. And also we need more information on protective factors. Great. Thank you. Okay, let's go to the next question now. The next question is, what opportunities for actions such as training, practice, research, or policy do you foresee for prevention of falls in midlife? So we're talking about action. And there was a comment by Marguerite, how about helping midlife adults to graciously move towards being older adults with adapting by keeping strong and aware of risks? So any suggestions for actions? They could be with training, practice, research, or policy, or anything else that you can see would be fit with this topic. Other than having more research, okay, I see sidewalk design. Oh, that's a good one. Currently, we promote aging well with 55 plus, and someone said curbs as well. Providing public forums and education. providing public education and information on the issue of falls, of midlife falls, workplace training and education. We use a qualitative tool called Photo Voice in people with spinal cord injury. It's been very useful and could be useful with middle-aged groups. Okay. Exercise programs specific to midlife population, as most of those are for older adults. Oh, that's a good one. Yeah. Anything else that you see that could be done? Integrate fall prevention messaging into physical activity opportunities for younger adults before they reach older age. Okay, sharing the falls information at gyms, community centers, where people are exercising. Oh, that's good. Oh, there's another one, which is a topic that I think that we're going to be treating in the next webinar, which is connecting concussion management as well. I want to bring my method of falling properly into research validity. Contact me if you know of specific interest. By the way, we're going to be keeping all your comments in the chat room, so that's all safeguarding for later. Raising awareness of the role of strength and balance in preventing falls and injuries. And then the whole age-friendly community recommendations that are for a safer environment. We need to show midlife adults that being an older adult can be wonderful if we have the best health and attitude. And finally, physician prescribing strength, balance, and flexibility as opportunities for action. Okay, lots of good ideas here. Thank you. Next question. How can we all address falls and midlife in relation to falls in later life at a program or provincial level? In other words, what can we do together to address this topic? Any ideas? Okay, I know you're typing away in the chat room. Yes?
As our participants are typing away and coming up with the ideas, I would like to contribute one.
Okay.
Last report from Parachute, the cost of injury in Canada, is beautiful in providing the insight of where the number of falls over the lifespan increases. However, what they cover the midlife as a period of time from age 25 to 64. And some evidence from the literature that we have reviewed just now shows that after the age of 40, that increase starts rapidly going up, and then it continues going up in later life. And I would recommend collectively at not just provincial, but also national level, we should ask for funding so that reports like this can be updated to provide better granulation of midlife period of time so that it's divided to early midlife, middle midlife, and later midlife, which would cover age of 40 to 64.
Great. Thank you, Alex. What the ideas that I got so far in the chat room, and so somebody is saying there should be caution in increasing alcohol availability, because as we just saw, it is an issue. Somebody else mentioned regarding impact of alcohol drugs, medical doctors questioning patients further on this topic as a preventative factor. I go into their home, work in home care, and I've seen alcohol bottles lined up, so it becomes more obvious to me the reason of their falls, but the doctor thinks it might be other medical physical reasons because patients are not admitting their addiction to the doctor, so the real risk cause is not addressed. Okay, so another person has mentioned, how do we reach these people? Lots of people in this age bracket are in the sandwich generation and are super busy. Women especially may be stressed out with all of their responsibilities and don't need any extra stress piled on top of them. Okay, so that's certainly a good consideration. We try to increase awareness among 55 plus by communicating information about preventative factors. Okay. Include in workshops for middle-aged adults, ask government to put more focus on prevention. Also, all of us who work in falls would benefit from infographics, brochures, etc. to share at forums, sharing events. And somebody else mentioned, same as older adults, falls shouldn't be 65 plus, but maybe 75 or 80. So I think that Kathy was responding that even in older adults, there are different brackets of age that are separate. People need to understand that frailty is much more prevalent than ever before, and working on going to and from the floor is one of the most important antidote to that. And another comment is all the same ideas mentioned above as part of education. When clients see us professionally post-fall, we try to get them to take an active role in maintaining or increasing level of exercise, strength, and mobility. Key fall prevention messages to midlife population, like postmenopausal women particularly. And more information from physicians when diagnosis is made. Increased risk of falls and injuries for special populations, particularly outlined in presentation. Include fear of falling in this midlife group. And yeah, and there's certainly something to be said about that. We'll come back to that. More opportunities for screening by health professionals and those who work with this population in physical activity setting, and need to move fall prevention beyond the healthcare sector discussion. And other comments is more public messaging, such as commercials, and get Public Health Agency of Canada to be more focused on falls, and use social media, such as Instagram and Facebook. So lots of good ideas. And somebody also said, echo screening, need more evidence to support this in midlife population. Excellent. So a lot about public education, a lot about screening, and fear of falling. I would like to grab Allison here for a little comment, because it has come up. I think there was an article that came up about that in the review.
No, certainly fear of falling has come up as an emerging issue, that people are starting to develop that fear earlier, and then that is affecting their risk for falling as it increasing. So the issue of looking at fear of falling is one that we've always looked at adding to the risk factors, not only and the causes of it. But also it doesn't usually get addressed, even considered, until after 65. So it was coming up in the midlife area.
Which was a bit of a surprise to us, but yeah, good point. Thank you. Okay, so next question. What collaborations and partnerships would be helpful to address falls in midlife? Okay, so I hear multi-sector, so definitely echoing the comment that was done to go beyond the health sector, so yes. Health providers, educators with fall strategies and training. Okay, parks and recreation, of course, fitness facilities. Yep. Gyms, medical clinics, community centers, sharing information at liquor stores about fall prevention. Okay, that's a good one. Municipal governments, street maintenance, excellent, yeah. Specialized geriatrics and acute care partnering with public health. Senior centers are including age 55 plus now, so it's a good partner to consider. It should start at the physician's office once diagnosis made, making patient at increased risk of falls and injury. Another suggestion is to partner with emergency departments, footwear retailers and manufacturers, primary care networks, service clubs, asked to be a guest speaker. Great, those are good suggestions. Wonderful. There's one more question. Oh, I just want to, yeah, and people said ladder retailers, DIY stores for ladder safety, hardware stores where folks buy ladders. Those are excellent, excellent suggestions. And you can still keep on typing. Now we'll go to the next and final question. What are the next steps and priorities for action to address falls in midlife? What can we do now? What could be the immediate next steps that we could take collectively? Okay, great. Continuing the conversation, and that's a good one, Kathy. We plan on doing that at the conference, the national conference. Hardware stores where folks buy ladders. Okay, we had said that. Continuing the conversation. This is scrolling down fast. Focus on social media. Okay, that's a good one. Post the questions on Loop 2. Actually, that's a good suggestion, Marguerite. We're going to be posting the one way to keep the conversation going, as Marguerite is mentioning, is that we will put the slides and the infographic and the recording of this webinar, and then we can keep having a conversation on Loop. And I'm sure that Alex and Allison can chime in. Okay. And share information about what interventions, services, supports people are providing. Okay. Make infographics for us to share. Oh, there's one. We have one at least that you can share. We'll give that to you. Start by asking all clients about their fear of falls and providing them with strategies. Partnerships with optical partners, wondering about falls and bifocals. Yes, that's definitely research does support that. Raise awareness of the provincial level with new OHTs as policies develop. So those are Ontario health teams in Ontario. Include this age group along with older adults. It's the healthy aging conversation. Research to explore different activity options that are age appropriate and appealing to middle-aged adults that also effectively support balance and strength. And connect to physical literacy, and that's been mentioned before. Educating public about free fall prevention exercise classes. Quite a few suggestions. Support universal fall approach versus using screening tools and facilities, as everyone has the potential for falls. Okay. Yeah, as we saw with the general population. Yes, that would be the case in midlife. Wow, there are certainly many things that can be done. I really appreciate your input on this, because we certainly want to know what else could be done after this scoping review, because there are some options. We want to keep that conversation going, and I do invite you to be part of it on Loop. There's another comment of what's the best approach to getting uptake from this midlife population group, and that's a very good question, and that's certainly something that we would need to discuss, as they haven't really been targeted in some respects, so that makes sense. So that's it for the question period. I see that we say expanding the age group that our own organization includes, and that's yes. So there would be a little bit of not only with middle age groups, but also our organizations, that they need to go beyond their current mandates of older adults. So that's a very good point. and free exercise classes, healthy aging at multiple different levels for different abilities. Thank you. This was an awesome discussion, and I'm so grateful for all your ideas. We'll try to summarize that as well. Maybe we can do that in the context of the loop discussion. So we'll try to put some themes together for that. And we encourage you to keep this conversation going on Loop and also at the conference in Saskatoon. And if you have other ideas, and this, as you said, this does not end here, so you can always forward them to Aleksandra, as you see, and myself for the next step. So I'd like to thank everybody for their input, and I'll pass it on to Shamiza.
Great. So thank you, Allison, Alex, and Alain for such a great presentation, for sharing your extensive knowledge on falls in midlife. To our participants, thank you for joining us and also engaging in such a wonderful discussion. So for more information about the fall prevention community of practice, please visit Loop at fallsloop.com. And if you're not currently a member, feel free to register to keep the conversation going. When the webinar has ended, which will just be in a few minutes, you'll be redirected to Zoom and invited to participate in a short survey. Just click the blue continue button on your browser and you'll be redirected to complete the survey. And we'd appreciate if you provide any feedback about this particular webinar so we can continue offering webinars such as this in the future. So thank you all, and I hope you have a wonderful day. That's all for now. So see you next time. Thanks.